Hi, everybody, and welcome to the July 2025 meeting of the Disability in Medicine Mutual Mentorship Program, or DM3P. My name is Suchi. I am the executive director and co-founder of DM3P. I am an Indian American woman with brown skin, black hair in a ponytail, tortoiseshell glasses, and this kind of bright blue embroidered top. And there's a blurred out image of my bedroom in my background. And tonight's topic will be about medical student accommodations, specifically needs assessment, data collection, and next steps from the perspective of three wonderful people from Drexel University College of Medicine. I now have the pleasure of introducing our guest speakers for the evening. We have three speakers tonight. The first is Dr. Stacy Ellen. She is a pediatrician who practices as an outpatient attending at St. Christopher's Hospital for Children in Philadelphia and at the Center for Children and Youth with Special Healthcare Needs. Her clinical niche is in the primary care of youth with autism. She's also a faculty member at Drexel University's Department of Pediatrics and an assistant dean of student affairs at Drexel's College of Medicine. In both her clinical and administrative roles, she teaches medical students and is a preceptor for the residency program. And her current leadership and scholarship work focuses on understanding and improving the experiences of students who need reasonable accommodations. So you'll be hearing a lot more about that work tonight. The second speaker is Kendall Smith. She is a fourth-year medical student at Drexel University College of Medicine, applying to psychiatry residency in the upcoming cycle. She is the founder and co-president of the Drexel Coalition for Disability Advocacy. She has led multiple initiatives focused on disability in healthcare and medical training, and her clinical interests include psychiatric care for children and adults with intellectual and developmental disabilities, with a focus on autism spectrum disorder. And then our third speaker for tonight is Catherine Mizzochi. She is a fourth-year medical student at Drexel University College of Medicine. Prior to medical school, she studied neurosciences and Spanish at Lafayette College and received her master's degree in medical sciences from Boston University. Her research interests include vestibular processing, sleep disorders, and disability advocacy. So thank you all for your patience, and thank you guest lecturers for coming and donating your time to sharing your wisdom with us. Welcome. And I'm really glad to hear from you, and I'm looking forward to learning what you have to offer. I'm now going to stop sharing my screen and we'll turn things over to the three of you.
Hello, everyone. My name is Dr. Stacy Ellen, as I was just introduced, and I'm very excited to be here today. One of my medical students, I think, put in a speaker form and is here today, and I'm grateful for this opportunity. I have auburn hair and new bright reddish pinkish glasses that are very big, and a white shirt and navy dress on, and bright bold light in the background, I guess I could say. So Kendall and Kate are going to speak with me, and I will start with my section. Okay, can everybody see my screen that is looking at the screen currently?
Yes.
Okay, great. All right, so the title of my talk today is Medical Student Accommodations, Needs Assessment, Data Collection, and Next Steps from the Perspective of a Student Affairs Dean and two selected student leaders. So a little bit of background. I became an assistant dean of student affairs at Drexel in July of 2022. And right away, I realized that there were an increasing number of students requiring accommodations, both for testing and classroom and clinical and other. But there didn't seem to be any change in the internal support structure to support students as they sought these accommodations and refine them over time. So I and my colleagues wanted to improve the support of this population of students that really needed more support than I think we had in place through the institution. And then simultaneously, students like Kendall, who you're going to hear from soon, and some of her peers, and I spoke about how they were seeking to improve supports for themselves and their peers, and starting to develop groups and leadership opportunities and talks and whatnot. So this presentation walks the audience through the needs assessment, relevant processes, research, analysis of results, and presentations of recent work in this area. So first, let's talk about the trend that I identified. So in my first academic year as a student affairs dean, I noticed an obvious trend. I began reviewing all of the student accommodations to understand the standard offerings. These included things like distraction-reduced testing and food and drink allowances, extended time, all-year clinical site placement, because we have a distributed model at our medical school, etc. And so we're at a very large university with a very large undergraduate population, many different graduate opportunities, a law school, a medical school, a robust grad school network, advanced nursing programs, a lot of different clinical programs, non-physician clinical programs such as physician assistant and physical therapy and nursing and the list goes on. So this one office called the Office of Disability Resources at the institution is caring for all of the students across the institution that have that need accommodations. And this office is kind of led by a wonderful leader who's been there for a bit. However, there was a lot of turnover among the people working in this group. So not only was it probably on the smaller side for the number of people was supporting, but also there was some turnover from time to time. And I started to try to get more FaceTime and more email time with the director there to get to know her better and get to know the processes better is what I would say. So my team then was instrumental in assisting as the go-between with individualized and nuanced student accommodations, as you can imagine, because there's this centralized group within the main university. But what happens when a medical student needs something very specific or nuanced, and how can we support them? So we don't have a disability resources professional, and we don't really have anybody in the med school that is the like point person. We do have 3 student affairs deans and a career advising dean, and we do have academic support, and we do have a psychiatrist and a psychologist. We have a lot of support, but that's something we did not have. So a student might come to us, or they might go to a clinical education dean, or they might go to a curricular dean, or they might go to a course director, or they might come in and matriculate and say, you know, I have this accommodation need, and what is a reasonable accommodation? And or the Office of Disability Resources might say the student has come to anonymized, the student has come to us, is matriculating, has low vision, what can be done for them in the doctoring course with respect to their blood pressure monitoring or otoscope use, or what happens when they go to the OR in their 3rd year, etc. So we were often the go-between between the office and then helping them get to the faculty member that they might need, helping figure out reasonable accommodations. So some examples early on in my time doing this was a M1 student with low vision who needed certain accommodations for a doctoring course, a student with a cochlear implant, a new cochlear implant between 2nd and 3rd year who had enhanced needs in the clinical setting then, temporary accommodations for skiing accidents and car accidents and broken limbs, which were more time limited. And then we had a number of students who had enhanced food and drink needs, whether because of type 1 or type 2 diabetes or other reasons for food and drink needs during testing that became more numerous over time, I would say. So in terms of enhancing communication, I realized that, so now we have this group within the university that's centralized, which is very good in the fact that they know what they're doing, they're centralized, they have their processes, it doesn't introduce any bias, right? Because they're doing the same thing for everybody across the institution. They kind of have the menu of reasonable accommodation options for the medical students. There are some times where there's nuanced accommodation needs. They come back to the faculty, and they keep an open line of communication with us. But I realized that we kept asking for meetings or kept emailing, and we weren't really having regular FaceTime with them. So I decided I wanted to meet more frequently with students requesting accommodations, but I also wanted to meet more frequently with Office of Disability Resources to understand their processes. I also started to ask a lot more questions in our meetings that we have among the student affairs deans and our assessment team, our curricular team, our clinical education team about how to better support our learners. And then 3 students, Kendall was one, formed a student group aimed to increase peer support, an alliance for students with accommodations, and she'll speak more about this during her time. And they even developed a presentation for M1 orientation to help people kind of start with the right footing as they matriculated to our school. So my program assistant at the time was helping keep a spreadsheet of all of the students' accommodations needs that we centralized so that assessment and our team in clinical education could utilize the spreadsheet to support students who had accommodation needs. And this was very much a need to know, very small group of people who needed to know what the accommodations were in order to implement them. And our program manager used this to then develop. I asked her to help me with some charting of trends because we felt the increase, and we realized that in the academic years, and I apologize that the one academic year after the year of COVID had very poor reporting or record keeping. I don't know, but that's the bar that's 4 bars in. That's like a maroonish burnt sienna kind of color. But otherwise, ignore that. In the other 5 academic years, there was a precipitous increase in our needs of our students for extended time on testing, and distraction reduced testing and excuse breaks, et cetera. So you can just see the trends, and the percentage need very much increased over this time period. And if you trended it over 24-25 and our upcoming and our now 25-26 year, the same trends exist. I just don't have those bars on the graph yet. So what happened then? So I actually was chosen to be part of a mid-career leadership program through the Academic Peds Association, and I was able to have a mentored project with a coach. And I said, well, this is what I want my project to be. I want to figure out how to enhance accommodations at my school, and I want to figure out how to make a business case for a DRP at my school. And that was what I sought out to do. But I'm not there yet, is the bottom line. But I started getting there through this mentored leadership program. And these are the steps I've taken. And I'm going to speak about each of these. So I wanted to learn the internal processes in greater detail and then elevate personal and group knowledge. Initiated and led monthly meetings. So I said that I wanted to really become more familiar with the Office of Disability Resources and have regular communication. So we actually have a standing monthly meeting now, which we did not have prior to a year and a half ago, with the Office of Disability Resources, Student Affairs, Clinical Education, and Assessment. I apologize that I left them out. And we actually talk through processes, improving processes, weak points, areas for improvement. We de-identify and talk about individual student needs to make sure we're giving individual students the right opportunities. And so everybody's in the same space talking about ways to help each other help students. I learned the processes. I interviewed individuals at 12 different medical schools through email communication and via Zoom with key stakeholders, and learned about processes at 12 other medical schools. And then I All roads then led to Dr. Lisa Meeks, who I'm sure many of you know through Docs with Disabilities and her many hats and her many publications. But then I was also able to interview her, which led to some other avenues of opportunity, which I'll speak about soon. And then internally, I met with the graduate student leadership and allied health program leadership because it dawned on me that making a business plan for something within the medical school and paying a salary for something within the medical school might go over better if I actually asked for it within the medical school plus the allied health professional programs and the graduate school, and it would be a shared budget model, and again, gold standard would be we had the salary support for just somebody for the medical school, but I thought the business case, just knowing being a little bit of a higher level admin at this point at the medical school and being realistic, I thought maybe a shared budget model would be a good start for somebody to help us with a DRP role. So I started to figure out the needs of the graduate school and the allied health programs a little bit of more detail. And this included meeting with individuals from our pipeline program, our master's programs in med ed, the nursing school, the accelerated nursing program, the BSN, NP school, the physical therapy school, the PA school. I really had a lot of meetings, but I really learned a lot through all of these meetings, and it was very helpful. So what happened then? My colleagues and maybe some of the students looked to me as one of the leaders and people who understand student accommodations in the med school space. And then I started being invited to relevant meetings with key stakeholders in the learning support and other programs. So other programs in the institution had me come to a couple of different meetings for different reasons. And then I began to have collaboration with the national leader, which is Dr. Meeks, in disability and medical education for local and national work. So some really cool things that came out of that. We did a 3-part webinar series for Tower Health, which is the hospital group that owns some of the hospitals where our students rotate, and it happens to co-own with Drexel, the children's hospital that I work at, St. Christopher's Hospital for Children. It is the sole owner of one of our biggest clinical sites and where our regional campus is, which is Reading Hospital in Reading, Pennsylvania. And so for the Tower Health Network, I was able to create a 3-part webinar series. We had a former resident in pediatrics who's now a pediatric attending in the Children's Hospital Philadelphia outpatient network at a practice in South Jersey. And she was actually on episode number 14 of Docs with Disabilities. Should you like to go back and listen to her Docs with Disabilities podcast? Her name's Dr. Courtney Corder Barnes. Dr. Meeks and I reunited with Dr. Barnes. So I had taught Dr. Barnes in residency. Dr. Meeks had interviewed her right when she started residency, I believe, on Docs with Disabilities. And we did a 3-part webinar series about best practices in accommodating an individual with a wheelchair and other physical needs during pediatric or other residency. What worked, what didn't, best practices. And then we had our program director, Dr. Shireen Kelly, come on and talk about it from a program director lens. So it was really neat. And if you contact me, and I'll send my email out onto the chat at some point soon, I'm happy to try to figure out how I can get those podcasts to individuals outside of our institution. Some of the other things that came out of that collaboration, and I know that there was some discussion in the first 15 minutes about ways to disseminate information through the AAMC and to administrators at medical schools. And one of the things that the AAMC started in the last couple of years is to have a listserv called the AAMC Communities. So, for example, I'm on like the medical humanities listserv for the AAMC Communities, and I'm on the holistic student support listserv. And Dr. Meeks and some others started a student with disability listserv for individuals who are supporting students in this space. And I'm just going to drop the name of that in the chat so that if you're a disability if you want to be on this disability inclusion community listserv, you know what it's called. And so I just put that in the chat. But she asked me to be one of the moderators on it. So that's another leadership opportunity. And I'm starting that shortly. And then there's been some other opportunities that have come up out of this space, which are really cool. So the number 6 on this list was that I figured that if I was actually going to make a business model, somebody's going to want some data. And my graph with the 600% increase was not going to be the only data that I needed. So I thought a little bit about what would make the business case for the DRP? What would my dean care about? What would the CFO care about? And it dawned on me that that gap between students with accommodations, going for accommodations on their USMLE versus not going for accommodations on their USMLE. So testing unaccommodated, there was good study from Meeks et al., I believe it was 2019, that it was something like if students, and the prior national pass rate before the pass fail was in the order of 96% or something nationally, and our local pass rate was a little bit higher than that. And when step 1 went to pass fail, the national pass rate dropped to the low 90s, and so did our local pass rate. But this study suggested that students who went into the USMLE, who received accommodations through their university setting but tested unaccommodated, had like a 67% first-time pass rate, which was statistically significant. So I wanted to know, well, what I felt that at our school, I felt that maybe there was disproportionate representation of students with accommodations in our step 1 fail, first time fail group. And so I started collating data to see. And I can't tell you definitively because I'm still working through the 3rd year data set, and now we're into the 4th year data set, but I think we have a statistical significant difference between the 2 groups. And I think there's a big percentile difference. So more to come on that. But what does that actually mean? Like what would be my deliverable? Well, my deliverable would be if a student doesn't pass their step exam on the first try, a few things happen. Number 1, what if our match rate goes down because of that? Well, I'm not sure that it has. So I don't know that I would hang my hat on that. But what I can hang my hat on is if a student is not successful on their first try of step 1, they almost definitively become a 5-year student. There are a few students that will make it through, that will pass on their second try pretty rapidly and be able to graduate in 4 years, but the vast majority graduate in 5 years. And what happens when a student graduates in 5 years instead of 4 years? The school has tuition implications. And what happens when you compound those tuition implications? Dollar signs. And what do deans and CFOs care about? Dollar signs. So could we save money by hiring a DRP to further support individuals acquire USMLE accommodations and support them through the process, and maybe support them with more targeted academic support? And maybe there would be a hybrid model of a academic support professional that learns how to become a DRP or something like that. And that's, I think, where my business plan is headed. So more to come on that. But the other thing I wanted to know is why or why not are our students going for USMLE accommodations, and what happens when they do? So I sent out to all of our students who have accommodations that we know about from our detailed spreadsheets that we need to keep so that we support them in a centralized manner. And I had 40 respondents to that survey, and I got some really nice data. And I think the deliverables from that are going to be, and this was 2nd, 3rd, and 4th years in the last academic year. So now 3rd years, 4th years, and recent grads, basically telling their side of did you receive MCAT accommodations? Did you request accommodations for the USMLE? If so, did you get them on the first attempt or no? If you didn't, did you appeal? What happened? What did you get when you got it? So that we kind of know the menu of options now of what our students are getting, which is great. And then some qualitative data at the end about like if they had to talk to other students about their experience, what would they say about the process? And we learned a lot about the timeline of processes. We asked students when they submitted and when they found out. The USMLE tells you 60 business days, but we're getting responses that are in the order of 2 months, which is 60 calendar days. So that's a little bit of a discrepancy, but not always. So we just, so we're going to make a FAQ. I think what I'm going to do as a deliverable is make an FAQ packet for students based on the study by students, for students, and then also use it in my attempt to get a DRP and maybe some mixed model of a DRP and an extra academic support professional. And then last but not least, I had not yet made my business model, and I was asked to go up for a mid-career leadership program internally when I graduated my external one. And I said, sure, because that's what you do when you're at my stage of your career. So, so I applied for and gained acceptance. Oh, that's a typo, I apologize, into the Drexel Launch Faculty Development Program. But what this program does is this takes leaders in the institution and tries to elevate them further, but also disseminates their work institutionally. And so in December, I will get to basically be in front of the dean, the vice dean, another vice dean, another senior vice dean, you know, all of the people at the table that I need. And I'm going to show them my project in December before they even get my business case on their desk. So, and they've actually, a number of them have heard about it. In fact, I had the dean's ear again today about it, and he was excited about that I was able to come and give this talk tonight as well. So I do have their support, and hopefully at some point we'll see this come to fruition with financial support backing it. Outcomes. So we have nearly threefold increase in student accommodations in 6 years, which was graphically represented, and it continues to increase. 9% of our students now have accommodations. We have 1,230 something students at any given time, plus or minus, and over 100 have accommodations for sure. So we're at about 99% to my knowledge. It might be creeping at 10 now. I have to look at the data for this coming year. There's definitely discrepancy in step one statistics between those with and without testing accommodations in the class of 24 and 25. I'm trying to complete the data set from 26. We had a couple people on leave that came back and are about to test. And once they test, I'll have a completed data set. And then the class of 2027 is in the middle of test taking at this point. So once I have 4 full cohorts, I think I'm going to be able to show statistical significance, but I'll have a much larger N. And then the WMC, if you didn't know, conducts 3 data sets, surveys of students, and one's at matriculations called the MSQ, one's at after year 2, which is called the Y2Q, and one is at the end of medical school, which is called the graduation questionnaire, the GQ. And the GQ is really very instrumental in looking at programs and getting feedback from students that then informs programs maybe need for being on monitoring for different weaknesses and things like that. For the purposes of this talk, there used to be a few disability and inclusion questions on the graduate questionnaire, but they were enhanced in 2024. So we have 1 year of our data so far from our GQ, which when you look at graduation questionnaire data, it shows you the national percentile and your school's percentile. So I can see all of the questions nationally, what the percentiles are, and all of the local percentiles. And we're going to analyze, I would like to analyze this data over 3 years. And then hopefully if we implement a change in our staffing model, the data will improve in the years after that. So stay tuned for that as well. And then, as I mentioned, 40 students provided excellent qualitative and quantitative data for the Step 1 accommodation study, and I'm currently analyzing it. And one of the products that will come out is an FAQ guide for the students based on the data that they provided to more junior students. So as I have said a few times, we're going to use all the data collected I'm going to use all of the data collected to make the ask for DRP or other model of increased support for medical students. Another idea that I had was to have a clinical programs specialist so if I can't get somebody within the med school or med school plus grad school plus clinical programs that's separately housed with us, then my other idea was to have all or a portion of someone's position within the Office of Disability Resources to be a support person that kind of really knows the nuances of all of the clinical programs. So that's another opportunity, should the other opportunity be not accepted. So some model of increased support for medical students with accommodations. I want to continue to speak to key individuals in all the health professions programs, explore new mechanisms for increased support for accommodations for the clinical years. I think the clinical years are a big change for many students. We also have this distributed model, so it becomes not only difficult for students to navigate going to somewhere new every 4 weeks, but also potentially moving to a new city for an entire year. If they're not successful in step one, their schedule gets changed out from under them, and because of policies that we have with regard to clinical education, it just gets a little bit more complicated. And then how can we increase internal support for student accommodation applications for licensure exams? For example, step one. Right now, our current model is that students reach out to the Office of Disability Resources for verification of their accommodations. Then we direct them to watch the 3-part webinar series on Docs with Disability. And then there's some links that we have to send them for their personal statement review, but nobody's internally is reviewing their personal statement unless they go to the Drexel Writing Center. So either we need to further train Drexel Writing Center folks on the needs of the personal statement, or when we hopefully have a DRP one day, that person would be in charge of supporting students through this. And then one of the things that I love to do as an academic, as a clinician educator and a, academic pediatrician and now student affairs dean, et cetera, is to mentor and sponsor the growth of others, which is why I brought 2 fourth-year medical students on with me, because I like to grow other people and watch them shine. We talked about the podcast episodes for Tower Health. That gave one of my residency grads a chance to get her story out and talk about how the institution was helpful to her and things that could have been better. I'm working on a publication that hopefully will come out in Academic Pediatrics next year on the transition from pediatric training to the workforce for individuals who identify as having disabilities in their pediatric training, and how program directors and faculty members can support not just during training, but in the selection, interview, and transition to their job after training. Then some oversight of student scholarship. So Kate, who is on with us tonight and will be presenting her study, which she has done a lovely job on, will be hopefully publishing her study soon and also hopefully presenting a poster soon on it. Kendall, who's also on, she and her group, we presented their poster at the AAMC national meeting last year about all of the student advocacy and homegrown work that their group did. And then I have another class, a student who was originally in the class of 2026, but she's out on a research year right now. And she is actually the student who right after STEP and right before starting clinical rotations, she had severe progressive sensory neural hearing loss unilaterally. And so then during the beginning of medical school, and then eventually led to the need for a cochlear implant. And so she received her cochlear implant surgery between step one and her clerkship fundamentals or clerkship preparatory class, which then led into her clinical year. And so she's actually done a lot of work helping overhaul some curricular things, which we're going to talk about on the next slide. But in addition, there was a call for case studies last fall for academic medicine, and I believe there were 3 chosen. But we had 2 students, one student who's the student I just spoke about who has the cochlear implant, another student who has a history of having dyslexia and some other learning differences, submit their own case reports. And they both had really good scores from the reviewers, but were not chosen in that final 3. And so Dr. Meeks actually reached back out to me, and she was overseeing the publication. She wasn't one of the reviewers, but she was overseeing the publication. And she said, I want to get these students case studies published because they were both excellent. So the student with her case study about the cochlear implant is going to have a mentored publication in Advancing Disability Inclusion in Medical Education next fall, which I'm super excited about. We just found out about this a few weeks ago. And then we have another student who worked with Kendall on a lot of her work, who's actually out on a research year devoted to more qualitative research about supporting students with accommodations. And his PI is Dr. Christina Peterson. So really exciting stuff. Another thing that I found out along the way is some of my colleagues who work in the doctoring courses and the clerkship preparatory courses realized that students really wanted to be better equipped to help patients who had different visual differences, hearing differences, mobility differences, etc. So some of the things that are being implemented based on student feedback include, and Kate will get out a little bit of this from what students wanted, and now it's happening this coming academic year, which is really exciting. Some of it's happening. So practical strategies to support patients and questions for functional assessment as a part of the standard social history, enhancing and diversifying the patient care panels that are brought in the doctoring course. I helped them bring in a Huntington disease panel this year, and then there was another new panel. But I don't remember what the other one was. I apologize. And then the case-based learning now has broader representation. So there's a case I helped edit of a child with autism. And then the health advocacy practicum now has an annual guest speaker on a relevant topic within working with individuals who have a disability. And then we also have a student video now on experience as a patient and on rotations with hearing loss, which is from the aforementioned student that I'm working with on her case study. And then we're trying to have her do a podcast about hearing deficit. I think she's doing one through a different venue now, which is great. Teaching the do's and do nots for working with visually impaired patients, and then teaching about basic physical needs and care, including transfers for wheelchair users. So really exciting curricular changes based on student feedback. We really take student feedback seriously. And though we have a very large student population, we hear them and we try to make changes as best as we can year after year. Why don't we keep going, and then we'll open up for questions at the end.
Hi, my name is Kendall. I'm a fourth-year medical student at Drexel University College of Medicine. I'm a white woman with long blonde hair. I'm wearing a black shirt, and I have a blurred background. I'm one of the students that Dr. Ellen spoke about that started an institutional group for students with disabilities, and I'm giving a presentation today titled Advancing Disability Equity and Support in Medicine Through Student Leadership. So this group was really born out of a lack of identifiable community and support for medical students with disabilities at our school. When I started, there was no formal group or way for students with disabilities to come together. And as many of us here are aware, the prevalence of disability within the population is quite high, with about a quarter of the US self-reporting a disability, but the percentage of people disclosing a disability in MD programs does not proportionally represent the population. And there are several reasons why this might be. Some is due to external barriers that keep disabled people out of medical school, but it's also due to underreporting due to fear of disclosure. And like Dr. Ellen mentioned, we've seen a dramatic increase in the number of students requesting accommodations, but structural support for us really didn't increase accordingly. And so some of the significant challenges I identified after starting medical school revolved around this lack of support, difficulty establishing community and trying to work around these barriers and isolation. Disability as a minority group is unique in that its members are often not visibly identifiable like other minority groups. And so this often takes a form of self-disclosure in order to create community. But there's historically been pressure in higher education to conceal anything that might be perceived negatively or as a weakness, which unfortunately historically has been disability, which kind of creates a barrier in establishing this community. And so this challenge in coming together and forming a network contributed to a lack of systemic support and united advocacy work that I found when I first started. And so this led to the establishment of the Drexel Coalition for Disability Advocacy. What was really important in starting this group for us was making sure that students felt comfortable being part of the organization without feeling like they had to disclose their identity to do so. And also to create some space for people who didn't have a disability but were interested in disability related work. So we intentionally chose a name of our organization that was pretty general regarding advocacy so that people could join and feel like it wasn't immediately identifying them as having a disability. And so we spent months collaborating with other offices and also leaders in the field who ran similar organizations at other institutions or supported individuals in running these organizations at other institutions, and collaborated with other offices within our institution and kind of formed structural support networks within the university to be able to reach and support more students beyond those that were kind of just plugged into our club. And it was also important to us that this group served as a central hub to serve multiple goals regarding disability work. So we didn't want it to just involve peer support, but also be a central hub for advocacy, disability education work, improving accessibility within our school, disability research, as well as community building. So one central element of our group was creating a form of peer support for students with disabilities. One way we did this was we provided, tangible ways of connecting. So group chats and discourse that were invitation only for privacy, and also creating social events, including like general hangouts, study groups, and things like that for individuals to be able to meet and talk in a casual setting. We created mentoring opportunities in the form of pairing first and second year students to help with the transition to medical school and navigating certain things like establishing accommodations or developing study strategies, things like that. And then we also frequently served as a place to crowdsource and share resources to navigate certain challenges that came up during our medical education. So some of this included people compiling local pharmacy availability for certain medications during medication shortages, so people weren't spending so much time calling pharmacies, or providing neuropsychological testing resources for people that needed updated testing to apply for licensure accommodations, sharing accessibility tools like speech to text services and different electronic modalities, as well as study strategies that worked for people with different disabilities. And then another main goal we worked on was improving both the accessibility of the curriculum and the representation of disabled individuals within it. So we frequently worked with administration to expand accessibility and troubleshoot any issues that came up, while also working within the general framework of universal design and trying to make sure that accessibility was available to everyone and not just people that requested accommodations. So this included things like making sure recorded lectures were frequently and promptly available, having closed captioning in lectures, and then also making physical accessibility improvements as we transitioned from one campus to another in the middle of my medical school education, improving things like access to accessible parking and transportation. And then I also worked on a team of 5 to spearhead a curriculum integration project where we surveyed student comfortability working with patients with disabilities, and then looked for places in the curriculum to boost exposure to disability, and kind of create a curriculum plan. We met with education committees and looked for ways to implement some of these changes. And then there were a couple times during the year where disability was presented in a questionable light in some of our, learning materials or learning resources. And so we also met with the education committees during these times to kind of improve how things were worded or how things were portrayed. And then we also work to enhance disability understanding among support staff. So some of this included things like interviewing candidates for academic support to make sure that they were going to be able to meet the needs of students with disabilities, and then also providing clinical accommodation resources to the Office of Disability Resources to make sure they were up to date with different clinical accommodations that students were needing or that were being provided at other institutions. And so one of the most energy and time consuming parts of being a medical student with disabilities for some is getting board accommodations. So even with the wonderful, resources out there, finding them, going through them, watching the videos, pouring through your own medical records, can truly be a part-time job for weeks alongside medical school education. And there definitely is a certain language and methodology that's required to learn to properly write a statement to receive accommodations. And so we really wanted to make this easier for students. We compiled these resources and distributed them so they were in a more centralized location. We hosted application workshops with students who had successfully applied for and received accommodations and did Q&A sessions. And then I and a couple other students met personally one-on-one with dozens of students, both at our school and outside of our school, to help them organize their personal medical records and write a powerful personal statement that would help them get accommodations. And then our clinical year interventions have been more recent, because when we started this organization, we were in our preclinical years and we did not have necessarily the experience to really contribute to this. But some of this has included making sure that accommodation continuity was smooth for students across the years and making sure that people received consistent support. And then also making sure that students were having an accessible clinical training opportunity and having an equitable training experience. Like Dr. Ellen was talking about, we don't have a medical specific Office for Disability Resources, so they are not necessarily as aware of what the accommodations are in a hospital setting. And so some of this has taken having conversations with them and letting them know what's available at other schools so that they can provide a more seamless transition and better accommodations. And then more recently, helping support students in navigating disclosure when applying for residency. A lot of this has come from crowdsourcing and compiling student experiences that have already gone through the process and allowing students to kind of ask those questions and be provided those resources. And then one of the most effective and impactful things I think we've done over the past couple of years was create an M1 orientation presentation. So this is a presentation that is given to the entire cohort of incoming students across both of our campuses, and it's been given the last 2 years. And it starts out as a kind of a grossly simplified overview of what disability is, the medical versus social model of disability, how disability affects healthcare outcomes, what barriers people with disabilities face receiving healthcare. And then we do some brief activities and talk about different disability language and etiquette. And then finally, at the end, we go through and talk about how to receive accommodations. If you are a student with disabilities, what accommodations are offered. And that receiving accommodations at the institution is totally confidential, which I think sometimes students coming in aren't aware of and prevents people from requesting them. And then we also talk about our organization and what we do. And I think this is done two really great things. Is one, it gets students without disabilities thinking really early on about disability and health and related health disparities. I think sometimes students in medical school aren't exposed to this at all or exposed very late. But it also provides students with disabilities with an immediate resource to go to with questions, which is often us, and provides them immediate kind of pathway to receive accommodations and the knowledge that other students at their institution are also receiving accommodations. I think some people come into medical school, they received accommodations throughout their life, but they're like, I'm in medical school now, maybe I can do fine without them, I'll try. And we really hammer in the idea that it's better to get them early and not need them than find out you need them and not have them. And so I think giving this presentation and letting people know that this is available and confidential and something that many students receive is really helpful in getting them get the ball rolling early. And then after our presentation the first year, we've kind of been frequently messaged by students who were there with various questions or difficulties they were having with accommodations that we were able to troubleshoot. So also seeing our face and knowing we're a resource has also been helpful for students. And so in terms of future directions, the big thing is going to be having this organization carried on by future years of students. You know, eventually we will graduate and we would love to see this kind of continue on without us. We're continuing to collaborate with the Office of Disability Resources to make sure we are supporting students to the fullest extent. You know, our dream goal would be to have a medical school specific or health scientist specific Office of Disability Resources. And then we really like to strengthen our support across the clinical phase in particular. Like I said, we started this as preclinical students who hadn't entered this space yet, and so we didn't really have the experience and expertise to provide guidance that we do now. So we're really working on that and improving our support in that area. And I think it's really important to have support staff who have the experience in training and working with med students with disabilities in particular, and also to be able to see physicians and educators who look and think like us in this setting. So we're also really pushing for that and making sure that the people supporting us have the proper training to do so.
Thank you, Kendall. I knew so much of what this group did, and I even learned some new things from Kendall's talk about things that they did that I don't think I realized. So thank you. We're going to move on to Kate's study that she'll present some of her preliminary data.
Hi, good evening. My name's Kate Mazaki, and I'm a fourth year medical student at Drexel. And tonight I'm going to be presenting about my project, Understanding Medical Student Perspectives on Disability and Medical Education, a survey analysis. And tonight I am wearing a blue blouse with some silver buttons down the front and some black slacks, and I have brown hair and pretty fair complexion. Next slide, please. So individuals with disabilities are underrepresented in medicine, and this is very well established. As Kendall mentioned in her talk, in 2019-2020, 4.6% of medical students reported having a disability, and this is a relative percent increase of 69% from 2016. Studies have shown that among students with disabilities in medical school, there are higher rates of burnout. And this is even more prevalent when individuals belong to groups that are underrepresented in medicine by race and ethnicity. Studies have also shown that there's higher rates of individuals with disabilities entering primary care specialties compared to their peers. What's interesting is that disability status may impact career opportunities even beyond medical education. And so one study from 2008 to 2018 looked at NIH grant funding and found that individual PIs who disclosed having a disability had significantly lower funding than those who did not have a disability. So our group was specifically interested in understanding when these differences begin to occur within medical training. Next slide, please. So we conducted an opt-in survey that was distributed to all medical students from the class of 2025 to 2028 at the start of this year. And our survey had a combination of Likert scale questions, yes/no questions, and free responses. And unfortunately, we had a pretty low response rate of only 118 usable responses. But we were specifically interested in assessing 4 different domains. So social support systems, social relationships, career advancement, and just overall medical school experience. We ran hypothesis testing on the comparable Likert scale questions, and then we did a further subgroup analysis to examine the impact of race and gender. So what our results showed was kind of 2 specific areas in which there were big differences between students with and without disabilities. So for the Likert scale question that asked students to agree from 0 to 5 with statements, students with disabilities reported higher scores for the following 2 statements. So the first statement is, I feel like I will be physically or mentally unable to pursue a specialty that I would otherwise favor. And students with disabilities had significantly higher scores on this. And when we looked at race and gender, there was a near significant effect of gender. Right now, that's kind of a preliminary trend, and we'll have to do more analysis looking into it. For the second statement, I feel well prepared to care for patients with physical disabilities in the future. Students with disabilities reported significantly higher scores than their peers. And for this question, race was a significant predictor. Next slide, please. We also asked individuals, what is one way you could be better prepared to advocate for patients with disabilities in the future? And nearly half of all responses focused on gaining direct clinical exposure to patients with disabilities, whether that be via a patient panel, simulate patients, or just modules on advocacy. Many people called for increased representation within the formal curriculum, which is why I'm super inspired by the work that I've heard about Kendall and Dr. Ellen doing tonight. Many people wanted to hear the opportunity to hear the lived experiences of patients with disabilities. And many people also sought out practical skills like how to transfer a patient from a wheelchair to a bed, or how to understand the disability paperwork that one day we're going to be responsible for attesting, and the proper terminology to use. Next slide. So in conclusion, at our school at least, students with disabilities feel that their career path is influenced by disability. Students with disabilities also feel more capable of caring for patients with disabilities, which is why it's so critical that representation matters in healthcare. Students are actively asking for more clinical exposure to patients with disabilities, so this is a good starting point for institutions to kind of work with. And there may be an impact of race and gender. However, our results are limited by a low response rate. Next slide, please. So in terms of future directions, at Drexel, there's work to be done, even though they do a great job. There's opportunities to increase exposure to patients with disabilities throughout the preclinical and clinical years. And so some of the specific ways that were suggested by students was standardized patients with physical disabilities, panels of individuals with disabilities and their support systems. And specifically at Drexel, we have a lot of emphasis on multidisciplinary education. And so having combined sessions with occupational therapy, physical therapy to work on gaining some of these tactical skills. We would like to distribute the survey to other medical schools to see if the experience that we're having is similar across institutions. Also, we've now found 2 areas where medical students with disabilities are reporting differences from their peers. And so there needs to be a follow-up, whether that's in the form of surveys or focus groups, to understand why that is and identify any potential barriers that we can address from a systemic standpoint. And so we also need to further investigate that impact of race and gender, but unfortunately, due to our limited numbers, that's not capable at this moment. But that would be something that we definitely like to look into more in the future. Next slide. And that's everything for me. These are my resources. They're really great studies, so please check them out. And thank you guys so much for the opportunity to speak tonight.
So we'll open it up to questions. And happy to take questions in the chat or questions if individuals would like to ask us directly.
Audience question, paraphrased. Could you talk a little bit about your process for helping students with disability transition to residency? For context, I'm a medical school graduate with a physical disability who ended up not graduating residency. My prelim year program said I couldn't be a doctor because of my disability, and I haven't been able to find another program since. My circumstances would be very different if my medical school had guided me on how to find a residency program that would support me. Once you're outside of medical education, trying to get back in is impossible. So I'm curious to see what Drexel has done to help medical students with disabilities transition to residency.
I would say, so as a student affairs dean, one of my hats is to be a career advising dean. And so when students differentiate themselves and decide on a likely career path in the middle of their 3rd year, they define themselves into a pathway. So for example, Kendall is entering the field of psychiatry. She's a fourth year now, and so she's in the psychiatry pathway, and she has dual career advising with one of my colleagues who has the student affairs dean career advising for psychiatry this year. So she has both a psychiatry. I just need to give you the background of how we structure our advising first so that I can then answer the question. So Kendall would have two advisors, her psychiatry pathway advisor and her student affairs dean advisor, who's overseeing the students entering psychiatry in this application season. And then Kate, I forget what you're going into, so you can tell us.
Neurology.
Thank you. And Kate's going to neurology, and same thing. So Kate has the student affairs dean who is career advising for neurology this year, and a neurology pathway director. And so it would, I don't feed forward information about, I know because I'm helping centralize the accommodations, are like tracking and our support, but like it's very neat to know, just like, a couple people from each group that need to know about the testing accommodations and implementing the curricular accommodations and clinical accommodations, et cetera. So I know who has them. And so if they come to me for career advising, I can address that with them, particularly if they've been my student affairs advisee previously and wanted to speak about it, right? But that's really a very individualized approach, because if the individual does not disclose, if I didn't know them previously, or if one of my colleagues doesn't know that they've had accommodations and it's not discussed during their career advising, either with their student affairs dean or with their specialty advisor, then it might not be something that they get individualized mentorship on in the residency application process. All of that to say that I think that there is a dearth of published studies about that particular transition. And I actually had Dr. Meek's ear about it at one point and said, can we do this study? Like, I don't think that we've had a great study about the residency application process and the like foray into like the first few months of residency. And that is a huge transition. So if you know about studies in that route, let me know. I've done some lit searches and I didn't see too many. But all of that to say, I don't think we have great models for it across the board. I think, if my advisee comes to me and says, I have low vision and how do I approach virtual interviews, I can, we can work together. If they say, if they come to me and they have pointed questions, I'm obviously going to give them extra support. The other thing is what I learned from actually doing the podcast with Dr. Corder Barnes. We talked about her interview process. She has, she uses a wheelchair. She has a very small stature because of the condition that she has. And we talked a lot about what did your career advising, and she was at a different institution for medical school, but came to my institution for residency, but what happened with your career advising? What happened during interview season? Her interviews were live, they were pre-COVID. So what happened during interviews? And it was actually really telling for her as a wheelchair user during interview season, because she would go to these different institutions and she knew how accessible they were. And then she had a visible disability and could actually see how she was received, right? But that's, not everybody has a visible disability. And now we also have a world in which most interviews are virtual. So I think it's so nuanced because it's the specialty, the person, the visible versus invisible, disclosure versus not disclosing, perception of acceptance, perception of welcoming, during the interview season, et cetera. We do have a mock interview series that we, and most students take up that opportunity. So another venue would be during a mock interview, a student could ask a faculty member that's mock interviewing to talk about it. So I don't have a great answer for you, but certainly as much support as we can give if we know that a student needs the support is what I would say.
Audience comment, paraphrased. I was told by my medical school that I was their first student who needed adaptive equipment in the clinical setting. So there were many novel challenges with that. Their advice was don't disclose, don't disclose, don't disclose. So when I soaked into a preliminary surgery program, I did not disclose. I waited until after I had signed my contract to tell them I had a physical disability and explain what accommodations I used in medical school. My program director met me a month later and told me that my disability limitations made me a threat to patient safety, said I couldn't work in inpatient settings, reassigned me into outpatient rotations, and didn't give me any credit for the year. I did everything I had been counseled to do, only to be told that someone like me should never have been allowed to graduate from medical school. This was despite me being one of the top students at my medical school. I got the largest scholarship they offered. I passed all my licensing exams on the first try and got all honors and high passes on my clinical rotations. All of this is to say that if students with invisible disabilities are advised not to disclose, there is a very real chance that they'll show up to residency and be told that they can't train at that institution. And once one institution deems you too disabled to be a doctor, it's very difficult to get another institution to take the risk of accepting you, even if you have glowing letters of recommendation or if you apply to hundreds of programs. Given your unique position to guide students with disabilities, I wanted to put it on your radar that something as horrible as what happened to me can happen to others.
Yeah, I'm sorry. I'm sorry about your journey that has not gone in the way that you wanted your journey to go. That doesn't sound like it's been a pleasant one. And I hope that you find a spot in the coming years. But what I would say to you is when Dr. Corder Barnes, and obviously this is an N of 1 at an institution of an N of 1, but when one of the things that she said was the most helpful for her was not only disclosing, but actually having her, the person that she was assigned to that helped her from the Office of Vocational Rehab, and her occupational therapist go with her and tour the hospital and figure out what modifications needed to be made for her to be able to respond to a rapid responsive code, to get into the PICU doors. The track pads, the ID pads were put. There were like lower ID pads placed. There were changes to the resident workroom door. Swing. We had a adjustable table in our clinic for her height and needs. So it was definitely a much better success story, I would say, in terms of her being able to get the support that she needed to have a more seamless transition. And there were certainly things that could have been done better. But that was just, and again, I wasn't part of her medical school journey. I was only part of her residency journey, so I can only speak to her story and my work with her as a resident. It sounds like the institution in which I work as a clinician did a decent job of both accepting her to the program and then modifying things that would otherwise have posed problems for her to give the care to the patients that she needed to give during her training. So there's some questions in the chat that I'd like to acknowledge. So let me go to those. Do you see any trends in your work around people with less or more apparent disabilities? Thank you for your work. Oh, I'm happy to do it. See any trends in your work with more apparent disabilities? I think more apparent disabilities. I don't know. I think we have in the GQ data, the national data in the GQ and the local and our internal data in the GQ suggests that the largest population of students with accommodations have ADHD as a diagnosis, followed by chronic illness and other learning disability, and then a lot of other entities after that. So I think that the biggest population of students that I'm working with who have accommodations either have extended time or distraction reduced testing because of ADHD. And of course, they only disclose their conditions if they would like to, but But sometimes you can glean from the accommodations, the kind of things that they might need. And also we have the GQ data now that's obviously collated and de-identified. But and then a lot of individuals with chronic conditions for which they need either testing accommodation, classroom accommodations, or clinical accommodations. So I would say those are the heaviest hitters in terms of numbers. So those are the trends that I would see. In terms of less or more apparent, I mean, none of those are necessarily apparent. So that's up to the individual to disclose what they have and what they need. And then get the accommodations that they need. And then if other things are needed, then they come back to us. Technical standard analysis. Technical standard impacts recruitment of the disclosure of disability by students. So I went on a webinar early in my journey of doing this work, maybe 2 to 3 years ago, 2.5 years ago, about technical standard language and making sure that it's inclusive. And then I went back to our technical standards, which were updated in maybe 2020-ish, give or take a year, and looked to see how inclusive our language was. And my former senior dean of student affairs, who's now has a vice dean role, had been instrumental in helping edit those, and our language was pretty inclusive for our technical standards. I also looked at our admissions practices a bit. I haven't done a deep dive. But in terms of disclosure, what we're doing this year, in addition to if Kendall's group does their orientation talk, ODR director comes and gives a talk to first years. And actually, it's not even going to be a live talk this year during orientation. It's going to be in what they're required to do in July before they come for orientation in August, because we want students to get accommodations earlier. So if they know about the process earlier, then they can get accommodations earlier. So it's one of their requirements for pre-matriculation to complete. So that's, I think, helpful, but not so much in terms of disclosure, but in terms of early accommodations. Fear around professionalism in relation to clerkship grading, where that exists in technical standards. I actually have a story from today of a student who was on an away and has chronic migraine, for which the student has accommodations and has another entity for which the student accommodations. Again, the student has disclosed to me, which is why I know their condition, and believes that there was an unfair grading at this audition rotation with regard to this. And then what's the take home here? Because this institution, what's going to happen with her grade, her letter of recommendation, her ability to match at this other institution that she thought was going to be a good fit as an audition. It's wrought with issues, right? And so the home institutions that hosted her for her sub-internship opportunities, everything's been great, but now she went off into a totally different institution and auditioned, and it didn't go as well. So there's definitely some things that happen with clerkship grading that still happen. And I don't know that we're going to fix all of that overnight, but as I learn about our weak points and snags along the way, we can make things better and we can address them. And then back to the Dr. I don't know if what the paper was by Dr. Meeks or somebody else that publishes frequently, but there is a paper about technical standards, and it suggests that if individuals can be the leader of the code and call all the shots, even if they can't physically provide, I don't know how many people here have read this paper, but even if they cannot physically provide chest compressions, they should be able to be on the team. That doesn't necessarily jive with every institution's idea of what students need or what residents need to be able to do with regard to standards, but I'm just putting it out there that there are other opportunities for valuable participation other than being the one who actually physically gives the chest compressions. There was a question about my former resident and who funded devices for her. There wasn't really a department for the institution. It wasn't really an office like in our school. Like if a student has accommodations for postpartum and lactation, they can get a breast pump. If a student needs a specialized stethoscope or a specialized otoscope or a specialized blood pressure cuff or X, Y, or Z, they get it through the Office of Disability Resources. What this individual is asking me directly was who funded our former residents' devices, and I think the institution funded the new ID track pads and the table that still exists. I mean, we still have it if anybody needs it, right? Like, I don't know that anybody's used it of late, but I think that was I don't know if that was GME funded or hospital funded. I don't know where the fund exactly came from. But we didn't have a disability resource office within the residency program. And then there's some more discussion about technical standards directly to me about how certain institutions add or remove language regarding federal and state laws and utilizing medical evaluations, etc. And then I think we went a little bit over time, but I think there's another question in the crowd right now with a hand up.
Audience question, summarized and paraphrased. What a beautiful presentation. Thank you so much for what you are doing. I really appreciate the curious, humble way you are approaching this issue. I also appreciate what you said about representation and connecting with lived experience. Fostering more inclusion by requiring DEI modules is a lot less effective than having a person in your social sphere, a patient you're invested with, a supervisor you admire, or someone you look up to, who has lived experience that diverges from yours. Interacting with people who have different identities from you has incredible power, but it's really hard to make it up the ranks with a disability. In light of this, what processes do you use to recruit people to increase the visibility and representation of people with disabilities in your staff?
So I'm not the head of our group. I'm the but I do participate in hiring in our staff. And we have had individuals who have work accommodations. So I know that exists in our university, and in many other universities. And we certainly were able to implement the work accommodations that were requested for that individual to be able to perform at her best at the time she was working with us. So I can say that with certainty. In terms of institutional hiring for academic faculty to increase representation, I could not speak to that at this time, but I think it's a fantastic idea. And when I get the ear of my vice dean the next time, I will talk about it. I think what I can say is that our vice dean used to be the senior dean of DEI, and Kendall and her peers actually went to, I won't speak for you, Kendall, but I'm going to just plug the nice things that you did. They went to this office and said, can we be a represented group within the diversity and inclusion community here at the institution, along with, underrepresented in medicine, LGBTQIA, et cetera. Can we be another subgroup that you oversee? And so his ear was he was aware of all of those conversations, and now he's our vice dean of education. So I think that the heart is there. And so I think I could put it on the table when I start bringing the business plan in as another way to improve representation and improve our ability to serve our students better by diversifying our workforce.